So we'll get this started off, my disclosures. As we all know, carotid endarterectomy is an excellent operation. It's been tried and true. It's got fantastic results. So why should we change things? It's done well for a long time. Well, there's a lot of reasons behind that. As we all know, procedures are becoming more endovascularly oriented. Minimally invasive surgery is sort of the go-to for these patients that we're treating. And when they come in and see you, they want the latest and the greatest. As you can see here on this slide, the number of cerebral aneurysms, coronary artery disease, thoracic aneurysms, abdominal aortic aneurysms has shifted from open surgical reconstruction to endovascular procedures over the last 10 years. The one area where that really hasn't happened has been in the carotid location. And there's a lot of reasons behind that. It's not because we don't have the technology, but certainly some of that technology may not have been the best when considering outcomes versus CEA. Sometimes to move forward, you have to look in the rear view, look at your past history, what's been done in the past. This is obviously a subset from the CREST data. As you guys are aware, the CREST data is probably the most robust carotid CEA and stenting trial that we have. It was a superbly run clinical trial. And what we got from this is that the number of strokes that occurred with CAS was nearly 2 times that of CEA. So the risk is certainly there. It's an inferior procedure based on stroke outcomes. Now there is a minor, and I will say extremely minor, benefit from an MI standpoint, and there is a little bit of a benefit to those patients, but it doesn't outweigh the risk of stroke. Endovascular intervention from a transfemoral approach carries with it inherent risk. Crossing the aortic arch is certainly a source of potential stroke. Crossing the lesion unprotected is also a secondary location for potential stroke. When you look at, again, that CREST database, as I'd mentioned before, lower MIs, but certainly higher risk of stroke. And that stroke does not outweigh the risk of having an MI periprocedurally. What's happened over the last decade? Well, lots of things have happened. But certainly, one of the biggest is that the number of transfemoral carotid stents has gone down precipitously over the last 7 to 8 years. And we look at this subset from the VQI database, in terms of patients who were treated for high surgical risk or our physiological risk, the number of CEAs has precipitously gone down. The number of transfemoral carotid artery stents have also gone down. And TCAR has taken up the bulk of those procedures. Year over year, TCAR growth is somewhere around 12 to 15%. So we've been treating all the high-risk patients for about the last 5 to 7 years. This is the CREST-2 registry, which hopefully we'll hear some data about this in the next 6 to 7 months. But I point this out because when they decided to run this clinical trial, it was very apparent to the lead investigators that many of the interventionalists did not have the same amount of experience doing transfemoral stents. And to overcome that dilemma, they decided to run a companion registry. This registry actually was intended to allow the interventionalists to gain experience before they started randomizing their patients in the trial. And through that process, 210 green-lighted operators were identified. That's a fraction of the number of interventionalists that are in the US doing cases. So I think it's important that we point that out. Around the 2012, 2014 time period, TCAR came onto the scene. Luckily, I've been involved since about 2014. What's changed? What makes TCAR so different? Well, it combines the advantages of surgical principles along with the minimally invasive endovascular technologies. We know the sources of stroke came from the arch, came from crossing the lesion. TCAR is minimally invasive, avoids the arch, avoids cranial nerve injury, has high reversal of flow protection, and is accurate. Because you're traversing such a short distance going from the transcervical carotid artery, it's easier to place that stent and you can be more precise. So this is just a description of how TCAR works if you guys aren't familiar, but you make a small incision in the transcervical carotid artery, you set up the flow reversal circuit. Once the flow reversal circuit is in place, you're protected. You can cross the lesion, you can pre-dilate, you can place your stent, you can aggressively post-dilate, and really have very, very little risk associated with the procedure. In fact, in some cases, I'm not proud of it, but I've been on flow reversal for upwards of 20 minutes when it was a hard lesion to cross. and that doesn't seem to have a negative effect on the patients. This is a nice registry looking at patients who had carotid endarterectomy, transfemoral CAS, and TCAR in the VQI registry. And again, it's isolated only to high-risk patients. And if we look at this data set, the risk of stroke is lower with TCAR than it is even for CEA. The stroke and death risk is highest with transfemoral CAS. So even in a robust registry, we're still seeing that TCAR outweighs the risk of transfemoral CAS and is on par with CEA. This is just another subset of those patients showing you that over a short period of time, TCAR also increases operative efficiency. So the patients are done more quickly, more safely, a reduction in the radiation exposure, and also a reduction in contrast administered to the patients as well. This is a nice slide because it shows you that TCAR can be universally adopted. It doesn't require a lot of experience. And this is looking at the outcomes from novice, intermediate, advanced, and expert level TCAR interventionalists. And what you find that at about 5 cases, there's a threshold that's met, and all the interventionalists meet that threshold in efficiency treating patients with TCAR. When you look at transfemoral CAS, this is actually a European registry looking at the number of patients that needed to be done in order to achieve a sub 3% risk of stroke. Somewhere between 400 and 600 cases had to be done to achieve a sub 3% risk of stroke. That's a lot. Now, we've gone almost a decade where fellows, junior faculty haven't been doing transfemoral CAS, and so I think it's going to be really interesting to see what happens in the next several months in regards to if this technology can take off again. Irrespective of the complexity, the bottom line is, for me, TCAR is extremely safe. So I'm going to show you 2 cases. These, I would say, are sort of out of the norm, but I think they're 2 very interesting cases. The first is a 76-year-old man. He's 7-centimeter thoracoabdominal aneurysm with severe great vessel disease and cerebral vascular disease. He has a history of a CABG. He's got a depressed EF of about 43%. I know the cardiologists in the room are saying, that's not so bad, no big deal, but it was somewhat depressed. He had multi-vessel great vessel disease. So a 95% innominate, an 80% left internal, and a 60% left subclavian. In addition, he had a previous EVAR with a chronically occluded left common iliac artery. So he's basically an aorto-uni-iliac reconstruction. And for us to fix his thoracoabdominal, we need to do a fenestrated repair. You can't do a fenestrated repair with a single side access, so you have to use the upper extremities. Having this great vessel disease prohibits us from doing that. So as a first stage, we had to address this. This slide is really just showing you his thoracoabdominal aneurysm, and as we get down to the bottom here, you'll understand why it is we can't treat him from the infrarenal aorta. He's only got one access point, being the isolated left iliac, or excuse me, right iliac. He will require an axillary conduit, and because of his cerebral vascular disease, he's at high risk for periprocedural stroke. So this is his CT scan, looking at, number 1, a very heavily diseased innominate with heterogeneous plaque, a very heavily diseased left subclavian with heterogeneous plaque, and then the left internal carotid artery, which is here in just a second. Additionally, some unstable plaque in the left internal with a roughly 80% stenosis. We had to address him simultaneously, so our proposed procedure was to do a left TCAR antegrade fashion, use that same TCAR sheath in a retrograde fashion to treat his innominate, and then ultimately do an antegrade left subclavian. These are his intraoperative images. So this is his left ICA, again with an ulcerated plaque, roughly 80% stenosis. This is after we deployed the stent, and again you see somewhat of maybe a 20% residual there. This is his brachiocephalic artery, again with a very tight lesion. We had the flow reversal sheath in the opposite direction, so if any debris were to break off, again, it's going to exit the body. And this is after we placed the 11 millimeter VBX stent. And then finally, his left subclavian artery, which again, we treated primarily because we were going to have to use that access to place his fenestrated stents. And then finally, that's in place. Next case is a 72-year-old man, acute onset of left upper extremity weakness for roughly 2 hours, Again, significant coronary history. His CTA revealed a 95% stenosis of the right internal at the level of the C2. Again, high risk because he's at the level of C2. This is his CTA here. Again, the red arrow is going to demonstrate to you the location of his tight lesion with some unstable plaque, a little bit of thrombus as well. He was initiated on dual antiplatelet therapy, but also simultaneously maintained on a heparin drip. We felt that he was extremely high risk given how tight his lesion was. So the clinical challenge here is a symptomatic high-level ICA stenosis, anatomically high, moderate grade of calcium, and a thin layer of unstable plaque and thrombus. We approached him in a very thoughtful manner. We maintained heparinization in the peri-procedural period. He was initiated on dual antiplatelet therapy. We confirmed effectiveness with a TEG. We established flow reversal in the operating room. And we paused flow reversal for roughly 2 minutes so that we could lace the stenosis with TPA, allow that TPA about 2 minutes to circulate in the stenosis and sort of dissolve some of that. We avoided pre-dilatation. We placed the TCAR stent. We post-dilated, and then ultimately did not reverse his heparin with protamine. This is his intraoperative image showing you the tight lesion in the ICA. Again, just a wisp of a lumen there with some significant plaque development. And then ultimately, after we placed the stent. So pretty good result. In summary, I think TCAR is the safest procedure that we can do in terms of stenting for the carotid artery. It provides a commensurate stroke and death risk that's less than, or that is on level with CEA and less than that of transfemoral CAS. Transfemoral CAS can be prohibitive in octogenarians and in unstable patients as well. And ultimately, at the end of the day, I think TCAR has already changed the way we practice. So I would like to end it here, and I appreciate the time.
So much. Thank you so much, Mazin. We'll discuss this over in the panel discussions. Let's move on to Dr. Teresa Carman. We need to have a multidisciplinary discussion on this.
All right, DOACs, NOACs, and Coumadin. So, there we go. All right, let me go back here. All right, so I don't have any disclosures. I do want to start by saying, just to define some terms for us. So DOACs, we're going to talk about DOACs as direct oral anticoagulants. NOACs is kind of an old term, so we don't use that. When we first had our direct anticoagulants, we called them NOACs, or new or novel, but that got misinterpreted as NOAC. So for this talk, NOACs will be the non-oral anticoagulants, i.e. parenteral agents. All right, I'm not going to refer to them as that. And then just for your own edification, Coumadin is actually off the market. We have warfarin and we have Jantoven, but Coumadin is no longer. So let's start with a case. So it's a 48-year-old lady who has a very complicated history of lupus. She's on DMARDs as well as steroids. She comes into the hospital with a fairly profound lupus flare. During her hospital stay, despite subQ prophylaxis, she develops lower extremity pain and swelling, and her ultrasound demonstrates right femoral popliteal DVT as well as left calf vein DVT. She started on a full therapeutic unfractionated heparin drip, and then we're called to help with what are we going to do with her. So her history is significant for lupus for about 20 years. She currently has lupus nephritis, although it's under control. She has a pericardial effusion, anemia, and diffuse joint symptoms. So fairly profound presentation for her current flare. She has an underlying history of cirrhosis. She's obese with a BMI of 37. She has a history of recurrent pregnancy loss. She is a G0 and hypertension. She has no previous venous thromboembolism. This is her first event. So the question is, what oral anticoagulant is preferred for her ongoing therapy as she transitions out of the hospital after we manage this flare? So how do we choose? Well, the guidelines are pretty clear. In patients with a DVT or a pulmonary embolism and no underlying malignancy, first-line therapy should be one of our DOACs, one of our direct oral anticoagulants, dabigatran, rivaroxaban, apixaban, or edoxaban. But that doesn't necessarily work in all situations, nor is it appropriate for all patients. So we'll talk about what impacts her choice here. Second, I'll ask, is an IVC filter a consideration? And we may have enough reasons to wonder about anticoagulation in this lady. So let's go on and let's talk a little bit about the direct oral anticoagulants. We've had these now for more than a decade. We know that they're very safe, they're bioeffective, they provide us ease of dosing, and they have a very broad therapeutic window. With that being said, we can't monitor them. Dose adjustments are typically not required, but there are some indications where they may be appropriate. The problem surrounds the inability to monitor these drugs, so we don't necessarily always know where we're at with these therapies. Off-label dosing is common, and unfortunately is also associated with complications, and they are still quite expensive. So how do we decide? Well, initially when you're in the hospital, one of the first things we talk about is let's talk about whether we need a short-acting drug or a long-acting drug. If the patient were to be going to an intervention or a procedure, if she's going to need biopsies, if we're thinking about tapping her pericardial effusion, et cetera, we don't want her on a long-acting drug, all right, or if there's a surgery planned, et cetera. We do need to talk about the potential for reversal in some of our patients. We have to review medications and make sure we don't have any drug interactions. And then we have a whole host of underlying comorbidities that may affect our choice of drugs. So liver disease, kidney disease, obesity, if the patient's had surgery of their GI tract, frailty in some of our patients, et cetera. All right, so what diagnostic studies are needed? The first thing we have to talk about is her liver disease, and we need to know how bad her liver disease is, and we need to know how bad her renal disease is. We have to assess her coags at baseline. I would like to know her anemia and what her status is, and does she have a history of antiphospholipid antibody syndrome? Because that's very important in your patients, particularly if she has another autoimmune disease. She's had her recurrent pregnancy loss. So when we get that back, while her ALT and AST is normal, her bili is elevated, her creatinine is reasonable, she has a low albumin, her coags are elevated, so we know her liver disease must be somewhat substantial. Her hemoglobin is relatively stable with a mild thrombocytopenia, but she has what we call triple positive antiphospholipid antibodies present. So she has a lupus anticoagulant that's positive, and she has relatively high titers, IgG and IgM of both her anticardiolipin antibody and beta-2 glycoprotein. And that certainly can impact what we need to do. So this is sort of her summary. Her Child's Pugh score is 9, which is class B. Her renal function is okay when we calculate it. Her weight is 100 kilos, and she has positive APLA. So what do we know about this? Well, in liver disease, despite an INR of 2, she still has thrombus. And that's because we have this balanced hemostasis where we have depletion of not only our natural anticoagulants and our procoagulants. So yes, we have an elevated INR, but that doesn't mean she's anticoagulated. She's actually still prothrombotic, and she's already demonstrated that. So we have to take that into consideration. We also know that in hepatic impairment, our DOACs may not be our best choice. Now, in child's class B, we may be able to use apixaban with caution, but I'm going to be honest, we don't know about whether or not she has ascites or anything like that. So she's sort of on that border between B and C. And in Child's Pugh C, none of our DOACs really have enough safety or enough experience to even be recommended. We just shouldn't be using these drugs. We also know now from many studies in APLA that DOACs are not appropriate therapy. So the first trial that was published was the TRAPS trial. This was stopped very early in the trial because there was an increased risk of thromboembolic events, and most of those events were stroke. That was followed with the Toledo trial, which did go to completion, but showed the same outcomes. And then the most recently published trial with apixaban went through multiple iterations of revision, but at the end of the day, also an increased risk of arterial thromboembolic events, and most of it stroke in these patients. So we cannot use our DOACs in patients with antiphospholipid antibody syndrome, and that's become pretty clear. So how do we choose? Well, it can't ever be just a gut choice. Even though DOACs have that first nod, it can't be just that. We have to decide, are we going to have a risk for intervention in this lady? If not, then we take into account what's her bleeding risk, what's her recurrent thromboembolic risk, and what else do we have to think about? clinical situations really have to drive our choices. So we should not be using this in advanced liver disease. We can debate what we should do in advanced renal disease, but we should not also use these in APLA. We have very limited data, although expanding in malignancy, and I think we do use this much more. But also I'm going to tell you in inflammatory states, I have a little bit of caution in these individuals. We have very limited data in arterial disease, some expanding data in cerebral sinus thrombosis as well as portal vein thrombosis. And we have to have a conversation with the patient. So in this patient, my optimal choice would be low molecular weight heparin. I think it's preferred in advanced liver disease. It doesn't require monitoring. It's well tolerated despite mild thrombocytopenia. DOACs are clearly not appropriate, and warfarin we're not going to be able to monitor safely in this lady. Her renal function is still okay, and we can monitor that very closely. An IVC filter is not indicated because we do have an opportunity to anticoagulate her, so I don't think we have to do that. And with her underlying inflammatory disease, I think it certainly puts us at risk for thrombus propagation and getting into more trouble. So, take-home points. The clinical comorbidities need to direct your choice of anticoagulants. Not everything just needs a hammer. We have a whole toolkit. When in doubt, ask an expert.
Fantastic. Teresa, thank you so much. We will move on to the next and then combine our panel discussion because there's a lot to talk about. So over to my dear colleague, Dr. Shishehbor, who presented the overall data from his recently published trial in New England Journal about deep venous arterilization. This is his opportunity to share some technical tips, which I'm really looking forward to because I have no idea how to do this procedure. So, Mehdi, over to you.
Thank you. Thank you so much, Subhash, and thank you everyone for being here. We showed the data this morning, so we're going to get into the technical aspect of this. Like anything that we discussed this morning, DVA is all about inflow, outflow, and the portion where you form the DVA. So the stent, and I mentioned to you this morning when we discussed it, we said there are 3 pieces to this procedure. You need the re-entry device to be able to get from the artery into the vein. You need the valvulotomy to be able to destroy the valves in the venous system. And then ultimately, you need the stent graft because there are those tributaries in the tibial, in the calf. You don't want to get proximal steal. There are also 2 terminologies that you need to understand when it comes to DVA. There is a proximal steal and there is a distal steal. So let's get into it. So what am I looking for is all about the ultrasound. The ultrasound is the foundation of performing DVA. You need to know about the inflow. Any disease in the inflow, even if it's moderate, can compromise the graft in the calf. That's number 1. Number 2, you need to know about the conduit. You obviously want to make sure that the conduit, meaning that the DVA is open and does not have any stenosis. Number 3 is about the outflow. Remember that the covered stent extends from the proximal tibial vein all the way to the ankle, to the calcaneus bone. Once we have the bifurcation of the medial plantar vein and the lateral plantar vein, we are back to the native venous system, and you need to understand what is the outflow look like and what happens to the ultrasound findings in the outflow if there is a problem. So we're going to walk through this. So I'm going to go through the case, which is the spirit of CVI, case-based discussion. This is one of my patients from Promise 2, 73-year-old female, diabetes, congestive heart failure, the whole shebang, prior IVC filter, significant vascular disease. This is a patient that actually was referred to me from 186 miles away from a colleague vascular surgeon who had previously treated her inflow. She has significant inflow disease, multiple stents in the SFA pop, prior endarterectomy, and so on and so forth. So that's their anatomy. I'm not going to bore you with the inflow because of time. The bottom line is that when you get to the outflow, below the knee, these are the things you need to look for. So we look for the AT, we look for the TP trunk, you see the proneal, and you see the proneal here, large proneal, and then you see the PT. In this study, as I showed you this morning, over 80% of our DVAs were done through the PT. Now, why is this important? You want to preserve the AT and the proneal and any collateral you can get to the foot because you can get what we call proximal steal. So meaning that if you destroy these branches, the patient will become severely ischemic, especially if the patient is dependent on the PT. And all of our patients have a single vessel runoff and is PT. And if you're going to create your DVA through the PT, you're taking out the PT. Now you have no blood flow to the foot. And now you have an ischemic patient, and the DVA takes time to mature. So those are the things that we're looking for when we're looking at the anatomy. Now, pre-TADV, before you do the procedure, you obviously want a baseline duplex ultrasound and a TBI to understand the anatomy. You want to know about the inflow disease. You also want to know about the tibial flow. You want to know what's going on with the AT and the proneal if you're planning a PT, a TADV. So that if there is a steal, based on the flow, you can tell that, oh yes, there is a steal, the blood is being stolen from the native arteries into the TADV, into the DVA, and look, my flow has declined in those tibial arteries, and that's why I'm ischemic. You want to obviously understand the native flow, as I mentioned, the tibial, as I mentioned. And then lastly, the most probably important part of the procedure, you need an excellent plantar venous duplex. Because remember, this procedure requires access into the plantar system. And as you know, in the foot, we have the medial plantar vein, as I've shown you in this picture, and we have the lateral plantar vein. The lateral plantar vein is key. If this is thrombosed, if this is very small, you won't be able to perform TADV. And the way we do this procedure is that you have to set up yourself in a way for success. So you want to make sure you're on the right side of the patient. You have the ultrasound here. Your hand is stable. This is not the location we get access usually. This is uncommon for us. This is very sensitive. All of you walk, obviously, and you know that if you step on something, it hurts. So you have to give a lot of sedation, and you have to stabilize. But bottom line is that it's an ultrasound-guided micropuncture access into a lateral plantar vein, pointing toward the posterior tibial vein in this direction, And this is what the angiogram looks like afterwards. Once you have gotten access into the lateral plantar vein and your wire has gone up the tibial veins into the popliteal vein, now you need to come from the top. And as I told you, my patient had significant disease. So these are prior stents that were placed by my colleague and significant inflow disease. But we can get access into these stents, and we can do whatever we need to be able to get access into the artery and come down. And currently the system we use is 7 French. So now we are down from the top, and we have a wire coming from the top in the artery right here. Remember, the PT was occluded. So we need to now recreate the PT because we want to see if there's any way possible for us not to lose this proneal. Because if I lose this proneal, what am I going to get? Proximal steal. Proximal steal. I lose my collateral to the foot. So once we have that, now we have the reentry. The reentry is straightforward, actually. It's actually the easiest part of the procedure. We have all done reentry using Pioneer and Interior. This is a specific device. Those catheters, the needle is too small and sometimes cannot reach through the tibial artery into the vein to get the connection going. But either use a balloon with a reentry device to be able to create the connection, or use the system that I showed you this morning, which comes from the LymphFlow company. Once you're here, you have now created a TADV, and now you have basically a blood flow coming in from the artery. You see, we kept the proneal as best as we could. We have the AT, so we don't get proximal steal. We now have excellent blood flow to the foot. Now we need to worry about something called distal steal. Distal steal. And what distal steal is that, you see all these tributaries and the small saphenous vein and so on and so forth. These can steal the blood flow from getting to the toe. And if you don't eliminate or deal with this over time, you never get the full revascularization in the distal foot to be able to save this patient's limb, because remember, these are patients with distal, most of them have distal foot disease, gangrene, and so on and so forth. So now this is where the duplex come into place. So we now place the TADV. What do we use the duplex for post-TADV? So first is that we need to get a duplex post-TADV the day before discharge. And what we're looking for here is volume flow. This is like creating a fistula. And the reason we focus on the volume flow is because we want to know the velocity and we want to know the diameter. We want both pieces of information. An ideal volume flow for TADV is 100 to 300. If this is high, there is a problem. If it's a low, there is a problem. And this goes back to our patient. So in this situation, you can see that post-procedure, this is in 2019, we did this patient. So we've done the procedure now. A couple days after, the patient is still in the hospital. She has severe pain. Even though we preserved the AT and the peroneal, she was having severe ischemia and severe foot pain. When we brought her back, we felt that this was based on the ultrasound, which I will show you. We felt that there was a distal still going on. So we decided to bring her back and coil some of these tributaries to be able to force the blood into the foot. There are three things with the ultrasound that we need to address when we do this TADV. So after the TADV, you want to know if the flow is too high, which if the flow is too high, it was hard, you damage the metatarsal venous plexus and you don't get enough flow to the foot. If the flow is too low, it means that the patency is obviously being compromised, right? There is something inflow going on that's compromising the volume flow into the, and people that do fistula work, they get this. This is fistula work, basically. And then we want to know that if there is any stealing vessels in the foot. So we want to do a nice ultrasound in the foot to understand. So what's the stealing vessel? So if you look here, and these are the nuances we are learning even more and more, but we are in the basically lateral parental vein, and we see that there's this little branch here. Well, it may not be a big deal, but when we go beyond the branch and we look at the volume flow, look what happens. We went from a volume flow of 166 to a volume flow of 34. We don't want this much of a drop of the volume flow. Remember, 100 to 300 is good. We don't want to go to 34 because this graft is going to go down because of an outflow issue. So in this situation, we see that there is this branch, and we need to come and eliminate this branch with coiling and so on and so forth. And in this situation, in our patient, we decided to come back and do a little bit more coiling in here, and now we are in this situation. So then we go to the TMA. Now, this is an early case from PROMISE 2 from 4 or 5 years ago. Now we have learned that when you do a DVA or TADV, you cannot primarily close this TMAs. Because if you close these TMAs, you get necrosis. Because remember, we have arterialized the venous system, and these veins can easily get damaged by sutures, by staples. You gotta allow secondary closure, so no primary closure. This is a mistake. You cannot put the staples in these patients. You cannot put a tourniquet on these patients. You have to really communicate with your podiatrist and make sure there is a clear communication before you proceed, because you can compromise and cause necrosis. So at this point, we opened up the sutures. We were learning about and getting more knowledge. We opened up the suture. There was still some necrosis going on. We decided to send the patient back for some debridement. And you see now they're getting a little bit more granulation tissue. It's getting a little bit better. It takes about 6 weeks for the TADV to mature, for the DVA to mature, for us to get this kind of granulation. Now we get into about 7 weeks from the TMA and 15 weeks from the DVA. Remember, this patient had some issues with distal steel. We are getting some granulation tissue. It's looking better. And here we are in December 15 of 2019. She was finally able to completely heal. And we just saw, and I have my team here, Elena, Mai, and Jenny, and we just saw her recently, and she's doing fantastic, correct? Okay, great. She's doing fantastic. Now, a couple more slides, and I know I'm out of time. I'm going as fast as I can, Dr. Banerjee. And you know I go fast, but still, you're killing me. This 8 minutes is not going to work. So remember the native arterial stenosis, the native arterial stenosis. So even though the velocity is 311, and many of us may not do anything about this, when you have DVA, you have to fix this, because you see that the volume flow is going down in the graft. So even moderate stenosis like this in the 300 range may need to be fixed. So ultrasound surveillance is key for the inflow. We need to understand the flow in the lateral parental vein. So this is a situation where the flow in the lateral parental vein is decreasing over time. So you see that the flow is going to 26.8. And we know that there is a problem proximally, because the volume flow should not decrease like this, distal to the DVA. And this is a high flow situation where you have volume flow rates of up to 1,112. And this is the most difficult one to deal with, because if you have a distal steel, you can coil it. If you have a proximal lesion, you can fix it endovascularly. If you have a high flow, it becomes difficult, and sometimes we have to coil even the actual veins that are going to the metatarsals to be able to slow the flow because there's too much flow going down the foot. So in summary, have a low threshold for duplex imaging. Remember, duplex imaging is key to picking the right patient and monitoring this procedure over time. We need to maintain the patency by understanding the inflow disease, intra-DVA, and most importantly, outflow. For outflow, coiling has become a significant portion of this procedure to deal with the distal steel and to deal with the high flow state. And obviously, we need excellent podiatrists to continue the wound care, and we need good communication from a standpoint of DVA is a different ballgame. You can't put tourniquets, you can't put sutures, you can't put staples, you cannot do the primary intention. It has to be secondary intention. Thank you so much.
Thank you, Mehdi. I think we'll move on to a panel discussion. You can stay there with the microphone and make some comments. I think I'll go to my panelists who are sitting further away from me. Let me talk about the elephant in the room. In the current atmosphere of intense focus on treatment options for critical limb ischemia across multiple forums and sources, do each one of your, keep it brief, do each one of your institutions have options for patients that Mehdi described through a DVA arterilization program? And also looking forward, many of you have launched programs both nationally and at your institutions. Do you think we need to have specialized teams who are equipped to handle the pre, intra, and post-procedural care of these patients? I'll start with Dr. Gary Ansel and then very, very quickly down the panel.
Well, I think that we should use Italy as our model because they have one of the lowest amputation rates in the world. And the reason they have such good amputation rates, they don't focus on discharge, they focus on outcomes. So they have their dermatologist who's kind of like our podiatrist. They have their radiologist, cardiologist, or vascular surgeon. They have the patient admitted usually for a minimum of 2 to 3 days, and they go through all the aspects of offloading wound care, making sure everything's really adjusted. They have uniform treatments so they can follow those outcomes. But I think the multi-specialty approach is absolutely imperative, not just because you're trying to save legs, you're trying to make sure that patient lives as well. And nobody does all that perfectly. It's only as a group where you focus on the patient, and then you can actually really justify your cost to the institution, who I'll turn over to Chris because he's running those institutions and he can give you that kind of input.
Well, I would completely agree with Gary. We have, over the last 8 or 10 years, developed these programs at Ochsner. At different phases of the patient's care, they're led by different members of the team. There's a time for the revascularization specialist to do his magic, as Mehdi has shown. Some of that work is more complex than we ever do in the coronary arteries. It is fabulously technically difficult. But there's other times when the podiatrist or the wound care specialist or even the vascular medicine person who's managing lipids and long-term survival becomes important. We lose money on these patients, right? So, because if you want to save money, they die quick, right? If they live, we simply keep investing. But we have to find ways to value patient function. The patient that Mehdi just showed is so much better off with her foot attached than she would be with repeated amputations, right? And they don't do well that way. So how do we value patients? How do we value patient outcomes? And we have to focus on that, not on dollars and cents, because it's hard to measure the dollars and cents in these short intervals. We just need to do what's right for the patients, and team-based care is the only way to get this done.
Dr. Iyer, do you have a comment? Go ahead.
Only one I can say publicly. I did have a question about the DVA and the likelihood of being able to put a shoe on and go to work in the PROMISE 2 trial. Do you have any feeling for that functional outcome that's relevant to a patient?
Right.
You can save a limb. I can save a limb in a bottle of formalin too, but it's not any more functional than, it doesn't help the patient. And sometimes I wonder about these. You're talking about a very long period of time trying to get a wound to heal, a high cost of deconditioning. People take this long period of time going back and forth to wound care. Meanwhile, all of their skeletal muscle is shrinking, and then you say, well, we've salvaged your limb, but you can't walk on it, and now you're unable to really function. So,
well, this is a 3-hour discussion. Unfortunately, as you know, and for appropriate patients, I think amputation could be the right choice. The reality is that a significant number of those patients actually don't get a prosthetic and have a number of complications from their stump, whether it's below the knee, above the knee. As a matter of fact, I know there are a lot of colleagues out there that don't even offer below the knee amputation to patients over the age of 80 because they believe that they are not going to get on a prosthetic because of the challenges of getting a prosthetic on. So the truth is always muddy a little bit. So to answer your question specifically, every patient in this study walked. And that was actually the requirement. The requirement for this study is to get the patient to ambulate immediately. We don't want these patients to be sitting because exactly what you said, Dr. Eads, is that they need to ambulate, they need to walk. This patient actually is doing line dancing, and she is doing fantastic. It's been 4 years, and my team is here. They can vouch for it. This is not me just making things up. And our goal is always to give these patients a functional amputation that allows them to walk, to be able to dance, to be able to do the things that they enjoy doing. And we're going to let them, it's a shared decision making. I cannot tell a patient what I feel, because maybe for me it's better to have a prosthetic, but for them it's not better to have a prosthetic. So these decisions to do goes back to also to our EVAR discussions and all the other Carotids and everything else that we discuss, is that these are shared decision makings. It may not be important to me, like, for me it's not important to eat meat. For other people, they can't live without eating meat. So we can't, kind of insert our ideas and our beliefs to our patients. They have to give us that feedback, and we have to make the decisions together.
Wonderful. I think we have covered some aspects of complex medical care, complex care of patients with carotid disease and CLTI, over to another vexing challenge for endovascular specialists and surgeons alike, and that is the challenge with dealing with calcification. And the first talk is by Dr. Zachary Rosol, When Do I Use IVUS During Peripheral Interventions, followed by Dr. Peter Soukas, Managing Severe Calcification. So it's going to be a duo. You're going to see some overlaps, and then we'll have a panel discussion based on what we hear.
Lucky me, I get put right in between Dr. Shishehbor and Dr. Soukas, but here we go.
I'm sorry, I just wanted to,
Yeah.
weren't we going to give the first presenter an opportunity to show the randomized controlled data for TCAR, because it's such a wonderful procedure? Been around for 12 years. The randomized data, was that going to come now?
I know, I understand completely. I think we will, we are going to have a lot of discussions to discuss the future of that randomized trial, but I think the point is well taken, and I do think that the selection of patient is where Mazin was saying is probably the key part of this. So, Zach, I think you
I'm
go
kind of entertained.
before
I mean,
Peter.
I can just sit down and we can skip this if you want. We can keep this conversation going.
Go for it.
All right, perfect. So we're going to back up and try to get a little less technical. I'm going to try to not get bogged down by any data with this. So I'm going to talk about when I get, ironically, right? I'm going to talk about when I use IVUS in peripheral arterial disease interventions and when I think it's imperative to, okay? So I don't have any disclosures. So what's the clinical challenge with all this, and why is IVUS important? Well, we've learned this in the coronary space. Sizing of stents, especially if you're going to put in a self-expanding stent in the peripheral space or anything that's not balloon expandable, I guess is what I would say, is really important, okay? Because once that's put in, there's no going back. You can't make that bigger if you need to. Defining how you cross a CTO is important because it opens up your therapies or takes certain therapies away or changes your risk of what you may do. And then, as we've talked about earlier this morning too, iliac interventions. I think it's imperative and it's a non-negotiable both for sizing and treatment, especially in the setting of calcium. So I'm not going to get bogged down with this. There is data looking at different interventions. Some of that is meta-analysis. Some of it is studies. This is up there for a reference. There's also, this is a study that just looked at and followed Medicare patients to show that those that with IVUS guidance did have decreased rates of Mayo and amputations. And that's all we're going to do for data. So we're going to get to a couple cases right now. I leave that in there for references. This is someone we actually just did a couple weeks ago. This is a 77-year-old gentleman who's got a past medical history as listed, prior tobacco abuse, moderate carotid disease. He's got non-obstructive coronary disease, anemia, and a post-polio patient, okay? He walks around. He lives out in Greenville, Texas. He can't walk to his mailbox, which is about 100 meters or about 100 yards away without severe lifestyle-limiting claudication. I put his CT scan up here to demonstrate the amount of calcium he has in his distal aorta, and also to look at the difference in his muscle mass between his two legs, okay? So arteries are somewhat proportional to the amount of myocardium, or I guess I should say muscle. I'm used to saying myocardium that they supply. Here's his ABI. It's 0.59 and 0.42 with monophasic flow at the common femorals. So he failed his medical management with cilostazol and a observed walking program, so we brought him in for an intervention, okay? I showed you the CT scan. Here's a still frame. We IVUS both limbs initially. And you can see on the right, the sizing, and on the left, there's 270 degrees of calcium. On the right, not as much, okay? So as a result then, our treatment, we decided to shock wave on the left and use kissing balloons. And here's our final result, and with a post-IVUS, which I did not include, but by just shock waving on the left and using appropriately sized stents with someone who has very different muscle masses, we were able to choose the right size and have a safe outcome here. Okay. Crossing CTOs and understanding the plaque morphology. So here's a 65-year-old gentleman. His medical history is listed here. Rutherford claudication with severe left lower extremity claudication. He can't walk across his house without his leg and buttocks just feeling numb. His ABI is pictured. You can see monophasic waveforms on the left, triphasic on the right. And on exam, he has an absent femoral pulse on the left. Wasn't sure if he had common femoral disease completely, and oftentimes we just do our diagnostics from the wrist. So here's a pigtail from the wrist. You can see he has a short segment common iliac CTO. We get common femoral access and are able to cross this relatively easily, actually. The picture here in the middle is just showing interaction with the wire and the pigtail. It helps me feel that I'm actually in the aorta and not in the wall before I advance the microcatheter. Just a little tip for people who do these. Before you make the hole bigger, if you can kind of confirm that you've got at least point-to-point connected, I think it's a little trick. And then we IVUS before we do anything else. There's a little bit of thrombus here, but predominantly soft plaque confirms that we're true lumen all the way through as well, and we get our sizing. As a result, we don't need to use lithotripsy, I didn't feel in this case, so we just balloon, choose a stent, and here's our final result. How about a little bit more challenging here? So how about assessing plaque morphology and the etiology of an occlusion in someone who's got a significant popliteal lesion? Okay, is this aneurysmal? Is it just atherosclerosis? I don't know if you remember this one, Subhash, from a month ago here. So this was a very challenging one for us. Okay, you can see his risk factors here as well. His ABIs are supernormal, so non-compressible tibial vessels. Okay, we talked about this one with our surgeons as well. They felt with his calcified tibial vessels that doing a fempop here was not necessarily ideal across the joint, and so we sent him for a walking program as well, and he just was not getting better, so we brought him back for a potential intervention. This was a little challenging. We got a 014 wire across it, and we couldn't even torque the wire. We tried to buddy wire. None of that worked. We tried to advance a small coronary balloon. We couldn't get it through there. We're hoping to be able to laser. We ended up having to externalize a wire all the way through his pedal access in order to have enough of a rail, and walked through serial dilations, as I've listed here. And now we have some flow, and we have a problem, so we likely have to stent, but kind of want to understand what's going on better first. So we IVUS. Large dissection, you can see these here, okay? Also in the mid SFA regions, and can help you decide too, if you have a large dissection with flow into that medial space, that those are ones that you likely need to place a scaffold. If it's a small dissection, you can likely get away without placing a scaffold. You can see the deep medial calcium here as well. We were able to size, and because we're going to stent across the joint here, imperative for a supera stent, we chose a 5.5 and ballooned aggressively afterwards with a 6.0 Mustang balloon, and this is our final results. And on his duplex ultrasound he had afterwards, he's got biphasic flow now all the way down to his pedal vessels. So why IVUS? A little summary here. understanding what the exact disease process is that you're dealing with leads to better treatment, okay? Iliac interventions, understanding the calcium burden, because the price to pay of trying to force open an artery in the iliac space can be catastrophic. Same thing for understanding how your course of crossing, either in the iliac or in the SFA space, is important and leads to your treatment algorithms. I've got a bunch more slides here that we're not going to go through. These are here for reference. If you want to download them, they're just examples of IVUS pictures in the periphery. So I will stop there and yield my time.
Thank you, Zach. Thank you so much. That was wonderful. And a lot of our presenters have additional slides, which we're going to be shared with all the attendees. Let me move quickly because we are a little bit behind. Dr. Soukas, who is a great friend and always has very challenging and nice cases to showcase at our meetings, is going to talk about severe calcification.
Thank you so much, Mehdi and Subhash. It's really an honor and a privilege to be here again and to be with you. So I'm going to talk about managing calcium, one of my favorite topics. These are my disclosures. So I think we've all, in our day-to-day practices, have been tortured by calcium. Why is calcium bad? It restricts vessel expansion. We can't get the vessel open. We have an incredibly high risk of complications, and they're all listed here. Dissections, perforations, embolization, recoil, incomplete stent expansion, and then the dreaded fracture. Well, we've had a number of different modalities that we've used over the years to try to deal with these rocks: scoring balloons, atherectomy. You're going to hear and see a lot about IVL, and obviously there's still an incredible role to be played with stents to tack up dissections and so forth. But the reality is, for a lot of these patients, we need combination therapy to really get a good acute result and chronic result. This is the Serenator balloon. It's kind of the new kid on the block. It's been around now for about a year or so, and it's really a very nice adjunctive tool, and we use it a lot more versatile than the traditional cutting balloons that we've used in the past. And here's an example of a pretty decent rock pile here that was treated very effectively with just a simple Serenator. How about atherectomy? Boy, people are talking a lot about atherectomy these days. But we still need it, and we still use it. So the new laser on the market is the Orion laser, which is this XMOB, neodymium lag laser, which is really quite good for these very, very heavily calcified vessels that you want to try to get a channel through. Plaque excision atherectomy has had a somewhat of a, I would say, checkered past. Great enthusiasm initially, but with the reality study, very reasonable primary patency rates, but a note of caution. Distal embolization in 13% of patients, despite the fact that there was mandated requirement for embolic protection, and 39% of these patients' specimens contained adventitia. And adventitia, as you know, is the last layer before you get a frank perforation. So here's an example of a moderately calcified lesion that we're able to treat, always, of course, with embolic protection, and a very nice acute angiographic result. What orbital atherectomy? We've been using orbital for a long time, both in the periphery and in the coronaries. And for superficial calcification, it's still a great tool, and we still use it. Here's an example of a common femoral, an area where we don't like to put stents in, that we're able to treat very effectively with orbital atherectomy, adjunctive drug-coated balloon angioplasty, a very nice result. But sometimes we need stents. And if you're going to use a stent, Supera is probably the one to use, especially if you're talking about the distal SFA and the POP. It has high compression resistance, low outward force, very flexible, extremely low rate of stent fracture. But vessel prep is an absolute must. If you do not adequately prep the vessel, you're going to have elongation and a much higher restenosis rate than you're going to be comfortable with. So here's an example of a patient where we use multiple modalities. We did a little orbital atherectomy, we did IVL and Supera stent. But far and away, the single biggest breakthrough in our practice has been the advent of intravascular lithotripsy. You're all very familiar with IVL at this point. Really has been a game changer because you can treat both superficial and deep calcium, very low atmospheres, and it's very, very safe, very effective. We know from other studies that have been done before that calcium, in fact, is a barrier to biological uptake. And so if you can get rid of the calcium, hopefully some of that drug will actually make it to the target vessel. Disrupt PAD, as you know, was a randomized trial of IVL in DCB versus PTA in DCB. But what I really want to focus on is the vessel prep. 77% reduction in type C or greater dissection, 75% reduction in the need for a bailout stent, and no embolization or perforation. So there was, in fact, an advantage in terms of primary patency, both at 12 months and 24 months. And this was true in both the observational study as well as in the randomized trial. But again, I would point to the angiographic complications. There's a lot of zeros up there. This is a very, very safe and effective technology. And this was also true in the below knee cohort of the observational study as well. So having done IVL now for about 5 years, we've learned a few things. One of the things that we've learned is that proper sizing is really critical. And I'm a big fan, like Zach, I'm a big fan of IVUS. I think it's really important in order to properly size your vessels. We typically will use 7 and 8 millimeter diameters for common femorals, 6.5 to 8 for SFAs. And then, of course, now we got the big boys available for the iliac. So let's jump into a case review. This was a patient, somebody's smart device, I'm going to allow that. Or somebody allow that for me, will you? This is a patient with a non-healing ulcer, was scheduled for a BKA, came to see us for a second opinion. You can see he's got horrible calcific disease there in his common iliac artery. And if somebody could somehow get rid of that for me, that would be great. Had a dissection which we treated with a self-expanding stent. Thank you very much. There was still a nice result after the stent, but then we used the 9 millimeter device in order to be able to get and treat that osteal dense calcified common iliac lesion. And we were able to get a superb result, complete resolution of the gradient. And then we finally got to the task at hand, which was to deal with this ugly, terrible multi-segment disease where basically everything is pretty much occluded. So we just put our heads down, started working, made sure we were well hydrated, and started crossing all of these lesions, did a lot of balloons, got some restoration of flow to the perineal, a couple of drug-eluting stents for the TP trunk, and then some IVL for the SFA and the popliteal, ultimately DCB for the below knee pop, ultimately placed some Illuvia drug-eluting stents, and were able to get restoration of flow. Did the same with the external iliac and common, treated that with a 7 millimeter IVL device, placed some adjunctive stenting after DCBing the common femoral. And after self-expanding stents, you can see here, we've got nice preservation and restoration of the inflow. And also the final runoff angiogram show very nice improvement of the outflow, direct flow to that perineal. And now you can actually see some pedal vessels down in the foot. Happy to tell you that this gentleman actually had resolution of his symptoms and was able to heal his ulcer. Here's another example where I think IVL really shines in patients with CLTI with single vessel runoff. The consequences of distal embolization are absolutely catastrophic. And the nice thing about not using atherectomy with single vessel runoff is you have much lower risk of any distal embolization. So we treated this with a 6.5 millimeter IVL, adjunctive DCB, and you can see here a very nice result. What about the dreaded stent result where you still have an hourglass appearance after you put the stent in? That's a bad feeling too. Not as bad as a perforation, but pretty bad, because you know that's going to be a setup for stent thrombosis and restenosis. So here's a case where immediately after post-dilating with a high-pressure balloon, we still had a 50% residual. Treated that with IVL, boom, gone. Stent expanded, problem solved. Finally, what do you do if you have a long, dense, supercalcified CTO and you've tried all your tips and tricks and you just can't get through? Well, just go around it. So this is the detour system, which, as you know, recently was approved by the FDA in June. So this is basically a percutaneous bypass. So you go from the ostium of the SFA into the femoral vein, and then go back from the femoral vein into the above knee popliteal artery, utilizing the vein as a conduit through which you can then deploy at least 2 or 3 of these torus self-expanding stent grafts using this dedicated detour crossing device. The primary patency at 1 and 2 years in the Detour 1 study was really excellent. The Detours 2 study was concluded here in the United States. The primary patency not quite as robust, but still very, very complex type C and D lesions in all of these patients. So this was a patient who literally was this big. Was turned down, had multiple failed attempts, was turned down by 3 different surgeons, and he had rest pain And this was a patient with just absolutely god-awful calcific disease of the distal SFA. You can see those rock piles, and we were able to get past the prosthesis, which was really a lot of fun trying to visualize. But eventually, we were able to get into the true lumen, and then after PTA, creating the anastomoses with 3 overlapping stent grafts, we were able to achieve 3-vessel runoff with resolution of his symptoms. So let me conclude by saying that severe calcification predicts reduced acute procedural success, increased complications. IVL has really been a breakthrough technology for treating not only superficial, but also deep calcified vessels that are very complex very effectively. We know with Disrupt-2 that also had an improvement in patency with adjunctive drug-eluting therapy. And in reality, we sometimes have to spend a little money to get a good result. And that means sometimes you're going to need an atherectomy device and a DCB and an IVL catheter, but if it gives you a good and a better acute long-term outcome, then it's worth it. Stents still play a role, particularly for dissections after intervention. We prefer the Supera for distal SFA in the POP. And finally, detour may in fact be the best option for these long, complex calcified lesions, or for example, patients who've had stent fractures or who have occlusive Tosaka 3 in-stent restenosis. I think these are all the kinds of patients that we'll initially tackle with detour. And for that, I apologize for going over a little bit. Thank you very much.
Peter, thank you so much. It's okay, we can take a few minutes into the break if everybody is okay with that. Can you please pull up Dr. Gary Ansel's slides? And I'm going to invite Dr. Ansel down. And while he's coming down, I'm going to ask Dr. Sai a quick question, just so that we get the discussion going soon. A lot of tools. And, 20 years ago, we just had balloon angioplasty and bare metal stents. Now we have all these tools, and what are your thoughts, Sherling, if you're a fellow just graduating or your early career, in regards to, learning and getting your armamentarium to be comfortable with using different tools that can help us get the results that Peter and others are showing?
I think that's a great question because there are so many devices out there. I mean, just trying to learn the catheters and the wires is a tremendous thing for somebody who's just starting. And I get this question from the fellows who just start. And I always tell them, well, you want to know not necessarily the specifics of each name, but like the general categorization. Like this is an 035 wire, this is a hydrophilic tip, this is a J tip, this properties of the things, and then know what categories they are, and then you will figure out which specific ones you like. As far as the devices, again, like the reason why there's not one device is because I don't think one device has been ever shown to be better than any other. So of the broad category of devices, everyone gets sort of familiar with the ones they are familiar with, and those are the ones they use.
And I asked that question because Dr. Ansel, who is world-renowned, he's going to talk about supply chain and a blessing or a curse. I think it's more of a curse. How to focus, on saving and being able to take care of these complex patients. And the tools are getting bigger, they're more expensive. So help us out, Gary.
Thanks, Mehdi, and thanks for having me this year. We're getting back to normal, right? COVID's on the way down. Paclitaxel may not be an issue. Carotids, whatever technique can be done. A New York paper is going after somebody again, and SVS is back to saying, not me, it's them. We're back to normal. But we all have one enemy, right? Hospital administration. So I'm going to hopefully help you deal with that. These are my disclosures, but we already talked a little bit about this, but we've got, with the post-COVID, we've got increased patient acuity, decreased capacity. The healthcare workers are all stressed out. They're all fighting. They all hate each other. Poor healthcare worker to administration relationships. We have less experienced people in our ORs and our cath labs. In the financials, the hospitals are all saying, I'm losing so much money, I don't want anything new because I know how much I'm losing. Go for it. The role of supply chain. Everybody hates supply chain. You should not. They help control costs. They manage inventory, which is your devices. They manage the supplier relationships to try to get you better prices. They manage risk so that we don't run out of stuff. And they develop a device strategy. They force you to do that. The realities are they're historically separated from reimbursement. There's little insight into the important stuff. They don't know a difference between a stent and a pacemaker other than price. Promotions are driven by cost savings. I'm talking about the administrator. Negotiating is a big part of their job. They don't know or understand the relationship between purchasing and research and relationships. There's little insight into advancements. Aren't all stents? And they need insight into episode of care, which is now a bigger driver. So the old days, it was the cheapest price. How much do I pay for it? Now they have to get more sophisticated. What's the best value? Which means price, clinical risk penalties, reputation and public disclosure, population management, and competitive contracting. Now, the upsides to a functional relationship, you should figure this out. You can be more competitive with your payers, less emotion, and help with value analysis, which we're going to talk about. Can take physicians out of awkward moments when the company says, can't you keep our prices up? Can help drive more uniform procedures, which are what hospitals and everybody want to see. They don't want 6 different treatments in their hospitals. They want there are plenty of commodity opportunities, and you guys should be working on that. We should be part of the solution, not the problem that we are right now. Working together helps them make better decisions. We decrease waste, especially of expiring devices. There's less unexpected, like equipment or medications aren't available. It helps build a partnership between the physician and the institution again. And we can hopefully help get a percentage of the savings to your division. Now, what's the new thing? Value analysis committees. Gosh, these are terrible. Because we came into existence because we as physicians wanted our stuff, sometimes for secondary gain. And that led to a huge excess in expenditures at the time of the supply chain purchase process. Now, as I talked about, a lot of the hospitals doing this with their VAC. They're making it even sometimes that line extensions means getting a longer stent has to go through the VAC. No doc at some institutions can be even approached by a company unless it's gone through the VAC. I don't even understand that one. The VAC is supposed to meet once a month, and oftentimes it's canceled, and they might meet every 3 or 4 months. And there might be a 9-month wait post-VAC, but we can't afford to do what we're doing right now. So as physicians, we got to get back on the ethical train. We have to drive valued care. If we raise the costs of regular everyday stuff like we did for healthcare, a dozen eggs would be $85 in 2009. A pound of bacon would be $129. And we're part of that process, every specialty, every interventional and surgical specialty. Because look at ortho, how many different implants do you have? Do you get paid more for giving a case on a stage or talking about a device? We got to be part of the financial realities. We should not be taking financial remuneration for specific device use. It should just not be occurring. Do not add duplicate devices just cause. That's just not going to happen. Work with supply chain and VAC to decrease waste. It's really important. What's the premise? Understanding the process and considerations that they have to take into consideration no matter where, on hospital campus, off hospital campus, is going to be an essential element for service and evaluation. What should we rename it? This is not rocket science. Business plan committees. So we did this at Ohio Health. If you're bringing a new product, it got evaluated in a business plan. Why? Because you have to be patient-focused. What's the competitive landscape? All the things in a business plan so that it had to make patient and financial reasonableness. If you want to bring something new to supply chain, let's just look at the process. First, you're going to be asked to be a physician champion. Don't do it if you're not really going to show up. Don't do it if you're going to get paid for it. Do it because you and the patient need to have that for better outcomes and to improve value. But keep it about the patients first and foremost. Less complex is always better. Better outcomes, less ICU, all those kind of things that you're going to really need. Discuss the competitive landscape. What's that new device going to do? Is it going to get rid of capital equipment? Is it going to get rid of service agreements? All those kind of things. All the things that could be the benefit for that have to be addressed. Define the unmet need of the current approach. Don't just go in and go, I need another hip. Okay, I need another stent. I need another atherectomy. Make sure it fits the puzzle. Can't hide complications anymore. There's public disclosure. the hospitals will lose money. Honestly, define the financials. What's the upfront cost? What's the uptake cost? What does it take to train my nurses and techs? What do I have to do to keep that on the shelf as we have more turnover? What's the effective length of stay? Is there increased revenue because I got more rooms that could get filled with something else? Are there other savings, decreased complications, population management? The insurers are paying attention to this. They're already helping the primary care label you as an interventionalist or surgeon because they want to go with the least expensive, and they're slowly defining that episode of care. But in summary, we're at a non-sustainable cost, excuse me, of today's healthcare in the U.S. If we physicians don't play a major role in reversing this, the patients get hurt. We need to work to develop insightful value with supply chain and value analysis committees, and we need to subject new devices to business plans. Thank you very much.
Thank you very much, Gary. And please, if you can bring up Dr. Peter Schneider's slides. And while Peter is coming up, I'd like to ask a question from Dr. Smolderen. The reality of it is that I don't care who you are, we all come into this with some biases. I think there is the one person in this room that doesn't have a lot of biases, and this is you, because you have dedicated your career to try to understand the patient. Can you share with us, from your interaction with patients and all the work that you have done in the field of claudication and CLI, what are patients saying, and what is their take, and what do they want? I know it's a loaded question, but if you can share a few things with us, that would be great, and we get back to it after Dr. Peter Schneider.
Well, thank you for that question, and thank you for the invitation. So I'm Kim Smolderen from Yale University, and big disclosure, I'm a clinical psychologist, not a cardiologist or interventional cardiologist. And I think the discussion about value ties well into how we see the patient and what outcomes. It was mentioned before, the emphasis on the patient-centered outcomes. We need to be looking at beyond the intervention and looking at the whole patient. One of the factors that predicts a bad outcome, the most predictive factors of readmission of a complication, is anxiety disorder, opioid use disorder, people with pain disorders. Those are the most predictive factors for having a bad trajectory or complications down the road. So to the point of the integrated teams that was made, I do think the tone has been set and the tide is turning for that. And I think this is what patients also want. They want to be seen as a whole person. They want their stories to be heard. And focusing on the healing of the lesion and the wounds is very important to them, but it affects their whole identity, their system, their family system, and so much comorbidities that they're dealing with on top of that. So, and this is not only their current generation, but also their children and the whole system. So I do think, yeah, I'm all for partnering together and building these programs like we're doing at Yale and piloting them and making them more mainstream available to people.
Thank you so much. Peter, we're going to give you the 5, you got the best talk. 5 inventions and techniques that has changed my endovascular practice. Thank you.
Yes, thanks. Thanks so much, both to Mehdi and Subhash, for inviting me. Yeah, this is a topic where there is no right answer, so I'm correct no matter what. But the truth is anybody could pick their top 5. And so what I did was, just by way of my own thinking, what I did was I limited it to those things which have come along in the past 10 years that I think will still be around and still be routine procedure in the next 10 to 20 years. So, and also primarily this is for peripheral artery disease that we're talking about. Let's see if we can get these slides to advance. Let's see, there we go. There's some disclosures. We're having trouble with the slide advance. There we go.
Green arrow, yeah.
What's that?
No, the top green arrow.
Yeah, got it. It's a little sticky for some reason. Okay, the integration of ultrasound into endovascular procedures. So the concept of the routine use of ultrasound for access guidance to reduce access site complications, and to optimize the use of closure. This may seem like a routine thing because it's come routine, but it wasn't routine 10 years ago, and definitely not 20 years ago when we were doing 18-gauge needle punctures through the back wall and using traditional Seldinger technique. Now we can pretty much get an accurate puncture using the 21-gauge and the micropuncture on everyone, ultrasound guided, and it's also stimulated our ability to really use these alternative access sites, which we weren't using before. And I anticipate that ultrasound will continue to be integrated. Here, just a couple of randomized trials looking at a reduction in complication rates. And keep in mind that every case we do may have something a little different than the case before. But the one thing every case has in common is access. So even if your access complication rate before was only 3%, and it was brilliant, getting it down to 1% probably helps more patients than any other single maneuver that you can do. And here are just some examples of the use of ultrasound for access. But now what we've done is we've started to use external ultrasound for real-time vessel sizing and also for intraoperative evaluation. We've started to incorporate pedal acceleration time into our on-table evaluations, et cetera. You also can use pedal ultrasound or pedal duplex to look at embolization and the risk of embolization. So number two, the other thing that's really changed my practice, and I think for most of us, is retrograde access. So prior to retrograde access, we were limited to antegrade only, where we could cross probably 80% of the lesions. And here's just some examples of retrograde access papers. They're everywhere now. This one on the left from Leipzig, I would consider the seminal paper, but they just did a recent upgrade of that. Nevertheless, all over the world, people have adopted it. You can see in this case, kind of interesting. So this I would not do now. You can see on the far, on your far right, that I kind of pushed the antegrade until I finally got a little bleed there. It's not really consequential, but now what I do is if I can't cross antegrade, I go immediately to retrograde. I don't waste the time. And there's specific techniques that I think are pretty well developed. There may yet come something else that I'm not thinking of yet, but it's really enhanced what we can do. The third thing I would say, and we throw this term around a lot, vessel preparation, but we really weren't talking about it 5 or 10 years ago. I think perhaps some of the really top-notch coronary people had in their mind what vessel prep was to get full coronary DES expansion. I think some of the real IVUS aficionados had in mind what vessel prep was, but the vast majority of us, I'd say 5 or 10 years ago, vessel prep really wasn't a concept. But, and even now, it's not completely defined, in my humble opinion. I think we'll see more development in this. The last two talks about calcification and about use of IVUS, you saw a lot of vessel prep going on there. So there are specific goals of vessel preparation. There are definitely several different kinds of technologies. Almost every definitive therapy we have can benefit from good vessel preparation. And there are specific tools for doing it, but I wouldn't say we've exactly established the correct or just the right protocol. My guess going forward is that a lot of clinical trials, rather than be based on specific devices, they'll be based more on algorithms of care that includes the vessel prep that leads up to the definitive therapy, just as the same way that the drug-coated balloon trials of the past 10 years have relied upon plain balloon angioplasty as its vessel prep. But we know that plain balloon angioplasty has disadvantages, so we have lots of other tools, and the question is when and how exactly to use them. And we heard, again, a lot about that in the last couple talks. The fourth thing I would say is drug technology. So we know that we can do pretty well with peripheral revascularizations using mechanical therapies alone, and we've had lots of different examples of those, different kinds of balloons and different kinds of stents. But the truth is that without biologic therapy to help make our mechanical therapies last longer, even though we can get across a lot of occlusions and get a lot of them open, we can't keep them open without added help. So drug therapy, I think, is now definitely firmly implanted in the peripheral vascular space and is not going to reverse from there. We may change up the drug. We hopefully will improve our use of drug in the BTK space over the next 10 years. But I think it's definitely here to stay. And here on your left, you can see this is the FemPop space, no paclitaxel versus paclitaxel, so plain versus coated, whether it's a balloon or a stent. In the upper right-hand side, you can see this is now a meta-analysis of one-year results of avoidance of TLR, and it's a 0.43 hazard ratio if you use drug. And then this last one is a 3-year results of the IMPACT trial showing a 25% benefit for the use of drug. So, and here are just the, not all, but most of the approved devices. Here are 5 DCBs and 2 stents for the FemPop segment. And then the last one I'm going to put, you might argue against this. I know Mehdi's given a couple of really great talks on this, but I really think the potential to turn the venous system in situ into a conduit for delivering flow to the tissues at risk when the arterial system is completely obliterated is one that is probably going to see a lot of future. Now, I would say the early DVA results, even though it's very close, I think, to FDA approval, even though it's been in the New England Journal, even though we have a lot of people interested in it, it's early days, I would say, and it's going to get only better. This is a guy, going back to the question that John asked, this is my first DVA case using the limb flow system, and the guy was a janitor. He worked 60, some years, and he went back to working once his non-healed amputation site was there. So, and again, you heard about this. I think accessing the lateral plantar vein sounded crazy and exotic to me when I first heard it. Now I'd say is absolutely essential to the technology and the PROMISE 2 data. We were lucky enough to be in PROMISE 1 and PROMISE 2, so got an early look under the hood. I think it has a big future. So these are the 5 things I picked. You could pick your 5 things, but I think all these things are going to be germane to our practice 10 years from now. So thank you very much.
Thank you. Thank you very much. I think I'm going to have the AV guys pull up a few slides from Dr. Kim Smolderen on integrated care. And while they do that, I'm going to ask Ben. Ben, you are at UH and you are a surgeon and you are at a 5-year stage in your career right now, Ben? Is that correct?
Yeah, fourth year.
Yeah, 4 to 5 years. So tell us, and you have probably trained with cardiologists and interventional fellows in your practice. So I would like to hear from you, your experience. How does the current structure of vascular care at your institution allow for integration? At what levels it is successful, and what are some of the areas of unmet need? So I know it's a loaded question. Pick it up where you think it is more efficacious for us to know. And in the meantime, I think our slide guys, AV guys, will pull up the slides for Dr. Kim Smolderen to make a few final comments.
Yeah, I think that.
Yes. Correct. Perfect. Go ahead.
Just in terms of integrated interspecialty care for critical limb ischemia, especially, my experience at UH is that we have basically interspecialty experts focusing on critical limb threatening ischemia. So it's not really a team of vascular surgeons or cardiologists who happen to dabble in, lower extremity PAD work. It's people who are 100% focused on that. And that allows us to really spread out the resources throughout the region in Northeast Ohio, and to get people the care kind of closer to where they are, which allows them to have that better follow-up and wound management. So I think the strength of this type of, cardiology and vascular surgery, both doing treating critical limb ischemia, is that we have more people to do it, and we're able to coordinate the care locally for these patients rather than forcing everyone to go to one area, to one main hospital to get it done. So I think that's the strength of that system. I think, one thing that I'm still working on, at least in my region of Northeast Ohio, is really integrating the wound care and podiatry services, and that's where I think we need to focus on getting, making sure we don't just drop the ball after we've done such a great procedure to get blood flow to a wound. It's like you really have to yourself go the extra mile to call that podiatrist, call the wound care center, make sure. It's very easy for these people to fall through the cracks. So.
Ben, would you say that that kind of integration also even improves communication within the specialty, meaning that because of that integration and that level of communication, even we are speaking more with each other within our specialty, meaning that us as interventionalists are more talking to each other when we get into trouble, meaning the siloed ideas that, oh, I saw the patient, I'm going to take care of it, is becoming rare in our practice, and there's a lot more communication both within the specialty and multidisciplinary. Would you agree with that?
Yeah, 100%.
I think this is a perfect segue for Kim to make some brief comments on critical limb ischemia and integration. I think this is a buzzword these days, and I think we really need to come together to make sure that the overall message of care of these patients is appropriate and interdisciplinary. So Kim, take it away for a few minutes, please.
Thank you for offering me this time. So a lot of the items that were brought up for the need of integrated care have been discussed, and it will come to light with the case presentation that we had put together. I will quickly go through these, but this is a younger female presenting with critical limb ischemia and hallux necrosis on the right foot, and has a lot of comorbidities, is a current smoker, and has a list of issues beside her: CLI, chronic pain, lifestyle factors that play a role, and her mood and suicidal ideation play a role in this case as well. So as you analyze this case, there's multiple issues going on at the same time, and if you are the peripheral vascular team, you will have to make referrals for all of those items that are going to interfere with your case. So this is a timeline of this particular case, of how long this plays out and how many referrals had been made to endocrine podiatry, smoking cessation program, and then to psychiatry, social work as well, and then to stabilize the patient with regards to her depression, suicidal ideation, the opioid use disorder. A lot of things was happening at the same time to prevent that this case would end in a bad outcome. And eventually, the patient underwent hallux amputation with orthotics and was able to come to a better functioning state. And this is also one of the guideline recommendations, of course, that interdisciplinary care is needed. But as we look what interdisciplinary care means, and these are publications where Mehdi has also been involved in, and others, and we see that this is ever expanding. And so, of course, I'm going to make a case to include behavioral health in those team-based approaches, because all of these tasks that are related to disease management are all interrelated, both from the behavioral health perspective, but also from the vascular disease management. So you can't really tease them apart. Quality, value, we look at the quintuple aim these days. We can't really focus on one aspect of the disease, but we need to look at the level of the population health, but also make sure patients get access to the right care, and that care teams are also not being burnt out, and that we control the costs as we face an ever-rising burden of vascular disease as well as mental health burden. This is something for people that they might want to look at to see how this role model of behavioral health could be integrated in the care setting. And then to this particular case, as I mentioned, there were successful outcomes by bringing all these specialties together. But then I come to the last slide. This was a fragmented care system, meaning that all these referrals had to be made, and it costs a lot of time and coordination. So in order for us to move to integrated care, we have to set up the teams in a way that they're successful, efficient, and work together. We have to work on co-training experiences between vascular specialties and other allied health professionals, so that we are most successful in optimizing outcomes and reducing costs and look at the whole patient. So those were my remarks. Thank you.